Well, good morning, everybody. My name's Paul. I'm a substance use specialist. I work with dependency, whether physiological or psychological dependence issues with substances, and then also addiction. Have our panel here. We're going to go into introductions. First, we'll start with the panel. Then we're going to go find out who's here and what do you want to get out of today. And then also, if you have any staffing cases that we can all come together, put our minds together, and hopefully offer optimal care. On my right is Dr. Lewandowski and then Dr. Patterson. So I'll turn over to Dr. Lewandowski for an introduction.
I'm Mike Lewandowski. I've spent the last 34 years working with people that have persistent chronic pain. And my background, I have a PhD in psychology, graduated from the University of Nevada here in 1990. And my focus has been for the last 34 years helping people cope, manage, deal with chronic pain issues. So I'm glad to be here. Thank you.
And I'm Dr. Dennis Patterson. I'm a physical medicine rehab doc who specializes in pain management. I've been treating patients with chronic pain for 10 years, and that's 100% of what I do, pretty much.
It's wonderful. And one of the ideas of bringing everybody together is to get the staffing, to help staff those complicated cases where you don't have to be alone. We have substance, we have psychology, and we have medical all represented here. But then we also have vast knowledge from our audience that we're going to tap into right now, so we can all come together for solutions for those difficult patients that you have, especially during this time where everybody has been tightening up. You'll see that pendulum swinging from where we were, and this is focusing on opioids, but you'll also see benzos and other medications also that are going to be tightening up, not only through PMP and pharmacy, but then also rules, laws, regulations, due to all of the recent problems that we've been having with opioids. So let's start off with
Nicola B. Nicola, you want to go ahead?
Yes, I'm Nicola Bain. I'm at Jackpot, Nevada, for Nevada Health Centers.
Hi, nice. Do you have a case today?
I was going to send it by next time. I do have a very difficult case. But
Yeah,
I
mean, if you just want to talk about it with us, we can absolutely do that today.
Yeah, after introductions, let's just go over it real quick to see where you are.
Okay, thanks.
Okay, thank you.
Mount Grant Hospital, who all do we have there with us today?
We're muted. Hello, we're muted, sorry.
We can hear you.
Oh, good, they can hear us. Dr. Ventura, introduce yourself.
Oh, can you hear us?
Yes.
Yes.
I'm Dr. Ventura, internal medicine.
Welcome.
David Rivas, family practice.
It is.
Toby Morris Hall, nurse practitioner.
Okay.
Hugh Qualls, administrator.
Good morning.
Good morning.
Morning.
And William B. Ryrie.
Hi, good morning. My name is Nancy Baker. I'm a family practice physician for the clinic, and I also work sometimes in the hospital. I just wanted to comment real quick that I noted yesterday on the Las Vegas Review-Journal newspaper that the head prosecutor, I guess it's the for Clark County, is going to join in a private lawsuit regarding a class action lawsuit against the pharmaceuticals. I think, and I noted that Reno is considering joining that also. So I think that there's maybe like hope to strike back, and that's all I have to say.
Thank you, Dr. Baker.
Dr. Chris?
I'm Mark Christensen. Currently, I'm a general surgeon, and currently I'm doing family medicine here.
Good to have you.
Becky.
Hi, Becky Bailey with Nevada Rural Hospital Partners.
Hi, Becky.
Hi.
And Alan?
Is he our technical guy?
Yeah.
That's really technical.
Oh, still can't hear you, Alan. I have you, you're off mute, but I can't hear you still.
Okay, we'll wave to Alan. Good morning, Alan.
And Dr. Koss?
Michael here, radiation oncologist. No camera.
Okay.
And Lindsay Morrison?
Hi, sorry, I was muted. I'm a nurse at a rural hospital in Quincy. I try to listen in to kind of gather information and help us improve our program.
Yeah. And Lori Skortzoff? Lori?
Well, good morning, Lori. And we also have Dr. Conright, who is a physician in geriatric palliative care, and she's in the studio right now with us. So, welcome. Good.
Thank you.
Okay, so let's start off with that case and see. We do
Okay.
first.
Okay, thank you. Sorry.
Yeah, you got it. Let's go. Let's roll. Get this puppy rolling. Okay, there we go. Okay, so today we're going to talk about opioid misuse and abuse, Naloxone, the Good Samaritan Law, medication-assisted treatment, AB 474, and the prescription monitoring program. So different types of opioids. We have the natural, that's morphine, we were just talking about in codeine. Semi-synthetic, these are the ones that we're seeing a lot of issues with overdoses. Hydrocodone, oxycodone, heroin, and then fully synthetic man-made opioids, which are their fentanyl, methadone, and tramadol. Okay, so when we're looking at all these statistics, there are so many statistics out that it's mind-boggling and we kind of get lost. So I like to keep everything around the Nevada area and see where we are. And so when I saw this one, and there's the publication at the bottom where you get the information. 2015, Nevada ranks second in the country for prescriptions for Vicodin, more than 88 million pills dispensed in 2015. So if we're dispensing 88 million pills, and then of opioids, then we're going to have some opioid issues. And now we are, we're stuck with trying to take care of the issues that come up with the prescribing in 2015, 16, 17. So when we're talking about multiple years of prescribing, we have, it took us time to walk into the forest, it'll take us a little bit of time to walk out because we've created this. When we look at oxycodone, that's also Nevada, ranks numbers 2 in the country for oxycodone. That's more than 61 million pills. 4,539 emergency room visits statewide related to opioid dependence, abuse, or poisoning. That's in 2013. So if we take, what is it, 365 days in a year? So that's more than 10 a day. That's about 12 patient visits a day throughout the state. 18,543 emergency room visits due to opioid dependence, abuse, or poisoning. This is death. We've seen a lot of scary statistics. 28,647 overdose deaths related to prescription pain relievers and heroin nationwide in 2014. Nevada's overdose rate for 2010 was 20.7 per 100,000. National average is about 12.4. So we continue to maintain that kind of average. Here's the problem. 4 in 5 new heroin users started out misusing prescription painkillers. Like we talked about before, if you start on Oxy, that's running about $1 a milligram on the street, and you have to get a prescription, and you have to see the doctor. So 80 milligrams is going to cost you $80. If you are physiologically or psychologically dependent on opioids or morphine, which it all breaks down to, heroin will do the trick. Heroin's only about $10 a baggie. Heroin is about 4 times more powerful than morphine. Oxy is about 2 times more powerful than Oxy. So it makes perfect sense that the person would gravitate towards heroin, either smoking or injecting. One of the big reasons that they say that they're using heroin over prescription opioids, it's not a preference, it's because it's cheaper and it's easier to obtain. Scary statistic, and they keep on going up. Opioid overdose. Overdose causes respiratory depression and can lead to death, as you know. Lack of oxygen from an opioid overdose may lead to brain injury in as little as 4 minutes. So that's another thing we have to consider. The person has overdosed. Somehow or another, they're revived after 5 minutes. What kind of brain damage is done to that person? And then how do we set up care for that person after that? We're just talking about the people that we've revived. What percentage of those have permanent brain damage or other internal organ damage? Most overdoses occur in the presence of others who could potentially prevent death. Here's the thing. The other people have a fear of police involvement and fear of arrest, which is the leading reason for failing to seek immediate help for someone who's overdosing. That's where we get the Good Samaritan law and naloxone. Naloxone is a drug that blocks the effects of the opioid by temporarily, important word, temporarily, reversing the effects of the opioid. The reason that's important is because one shot might not always do it. The shot lasts approximately 20 minutes, but if the person is overdosing and they have an abundance of opioids in their system, this might relieve the opioids, but then the opioid comes back and covers up the receptor again. So you might need a couple of shots. It works in 2 to 3 minutes, depending on what was used, but wears out faster than the opioid. So again, you might need a second shot. Second dose might be necessary. Anybody can administer naloxone. There's no side effects. So if the person's on meth and alcohol and, well, alcohol's not a good one, but meth and marijuana, and you think they're overdosing, you give them naloxone, it's not going to impact them negatively. There's no potential for abuse. Won't harm a person who doesn't have opioids in their system, and there's no effect on overdoses resulting from the use of other drugs. So where do we get it? Northern Nevada Hopes has a syringe kit for about $25. Contains 2 doses, which is important, and must establish as a patient at Hopes. So you go in, establish as a patient, and then they can get you hooked up with that syringe kit. Now there's also a nasal spray. They have all kinds of fancy ones too. There's one that actually talks to you that you can inject. That's about $5,000. So they go all the way up from 25 to multiple thousands. There's a nasal spray, various forms of syringe kits. They're available at pharmacies like CVS and Walgreens. The cost depends on insurance or cash payment. And they can be available without a prescription. So you can walk in, or somebody can walk in and get one of these kits if they think that their group or somebody in their group might be in need of this. But you can't use insurance without a prescription. So if you're going to use your insurance, you need to get that prescription first. Here's the Good Samaritan law. So it recognizes that people are not going to jeopardize their freedom a lot of the times if they're in the presence of somebody who's overdosing for fear that they're going to get caught. So this is the motivation behind the Good Samaritan law. It allows people seeking medical assistance for a person who is experiencing a drug or alcohol overdose or other medical emergency. They may not be arrested, charged, persecuted, or convicted, or have his or her property subject to forfeiture, or be otherwise penalized for violating certain provisions of existing law governing controlled substance, a restraining order, or if they're on parole or probation. The idea is that you get in, we're going to get the person the help that they need. In brief, there's no prosecution for simple possession and use. So seeks medical assistance defined as reporting a drug or alcohol overdose. Assists another person to report it, provides care to the person experiencing a drug or alcohol overdose with other medical emergencies while awaiting arrival of medical assistance, delivers a person to the medical facility or notifies the appropriate authorities. This isn't going to fly, folks. This is a different story. This goes under the child protective laws. Do you see Junior in the back? This is Grandma, Grandpa decided to take him to school one morning. This is from heroin use. So this will fall under the child protective laws of Nevada. So there is a line. Medication-assisted treatment. Matt. Has anybody been using methadone, buprenorphine, or naltrexone? Dr. Baker.
Yes.
What?
I have been using methadone on a patient. I inherited the patient, and she was up to 300 tablets of 10 milligrams a month, and I've weaned her down to 200. She is feeling better. It's been quite a challenge to do that.
What are some of the challenges?
She doesn't want, of course, to wean off rapidly. She does have chronic pain in her knees and her feet, and she's obese, and she smokes, and she wants to walk, and she wants to lose weight, but she is not.
Okay, what is her goal?
Her goal, and she tells me every time I meet with her, I want to get off this stuff, and let's go down to, a different amount, like down to 170 for about 2 months. And then she wants to go down. I mean, we're trying to go down every 30 days, 30 tablets, but it's been difficult.
You bet. Any feedback from?
Yeah, it's very tough, those patients. I mean, at least this patient sounds motivated. A lot of times I see these patients and you try to convince them to wean down, and their brain is so tied into that reward program of, every pill means pain relief, that a lot of times patients don't, resist or think I'm crazy for wanting to wean them down. So at least in this case, you've got a patient who's motivated and willing to do it. I see nothing wrong with going slow. You don't have to do it every 30 days. I have patients that maybe we reduce them by 5 or 10 pills a month. As long as you're trending in the right direction, it sounds like you're doing the right thing. It sounds like the patient's motivated. If you get to a point where they're having issues, you may want, I think when you're weaning somebody off, having somebody to be there psychologically for them, as well as medical wise is key. And so you may want to, as you get lower and lower doses, get them in to see somebody at least once or twice a week to keep that motivation up.
I would also maybe encourage her to ask her what she would expect would help her, kind of get her feedback, her involvement. We tend to want to give answers for people, and often, and many of them can be very helpful. But if you solicit some ideas from her, what she may think could be that one small first step that she could take, that she has confidence in being able to do, now you're getting her to be invested in this change process. So.
And if her goal is to lose weight and be more active, I don't know, you didn't mention physical therapy. You may want to get her involved with them. They may be able to start getting her in a program to get her moving, which would hopefully help with the weight loss.
And even if physical therapy is 1, 2, 3 times a week, that's giving her some structure to get out of the house to start to go do something. Just making that appointment would be a start.
Well, that's where the medication-assisted treatment comes in. The medication is a tool. It's there to assist in getting to the treatment goals. And so we need the patient's buy-in, we need them to be accountable, and we need them to put in the effort and have their goals and exit strategy. So when we're looking at the medication, if we're doing medication management, that's different than medication-assisted treatment. Medication-assisted treatment is that. It's a team approach, it's a counseling approach, and that's where we're going to be moving a little bit, because we have the methadone. These are the 3 medications that are indicated for the treatment of opioid dependence. Methadone, buprenorphine, that's Suboxone, which is buprenorphine and Naloxone, and then naltrexone tablets and injectables. Now, naltrexone tablets don't really have that good of outcomes. The injectables have much better outcomes, and that's because when you put in the injectable, it has a coverage for 28 days, the mu receptor coverage. So the idea is for alcohol and for morphine that the receptors are not going to be impacted to get that person a feeling. And so the philosophy there is if they're not feeling anything, then they won't be using it. And if they know that they have an injection in them, then that could be a deterrent. Buprenorphine is about half and half. You guys are antagonist and agonist working together. And methadone has some good outcome studies, and that's kind of a maintenance type of program depending on the treatment that you choose for the patient. Now, no single treatment is appropriate for everyone. Everyone is different, and that's why it's interesting when somebody comes to me and say they're from the court, and the court says, okay, give them an evaluation, and then I guess make them go to 2 AA meetings a week. Okay, well, that's not appropriate for everyone. It's cheap and it's available, but they probably need a little bit more, because the way that addiction strikes, you have the emotional stuff that's hit first that the person wants to cover up. Then you have the mental side. Then it strikes physically. When it strikes physically, that's when it's pretty obvious. This person's a mess. We got to take care of them. So the way we take care of them is to get the junk out of their system, and that takes about 8 to 10 days. It's detox. Then we deal with the mental. That comes back relatively quickly too, because the mind is resilient, and it's always fascinating when they can remember what happened the day before, or how about the week before. Now they're getting their cognitive functions back. Then we deal with the emotional. The emotional, the depression, the anxiety, all that stuff that made them reach out for it in the first place, that's where the long haul comes. Treatment does not have to be voluntary to be effective. If you see somebody who volunteers for treatment, that's like volunteering to go to prison. I haven't met anybody who's really said, I really want to go to treatment. I've seen a lot of people who are kind of nails in the carpet and you can't make me. But then after the 2nd or 3rd week, after they start feeling the effects, they get the payoff of their body coming back and their brain coming back and their relationships coming back. Then they start to understand it, and then they kind of buy into it. Treatment needs to be readily available. That's another thing. If we're waiting, there's a sweet spot. When that person is usually after they've used if they go through a depression or anxiety, hangover kind of area, there's that sweet spot of incomprehensible demoralization where they are available to listen to someone. They're down as low as they can get and they're reaching out for help. That's when we got to get them and get them into help so that we can surround them with care and all of the things that will be beneficial to them. So treatment plans also need to be assessed and modified as necessary to ensure the needs of clients are met. Sometimes you get an evaluation. So when I go through an evaluation with somebody, it takes a couple hours, and I have to let them know that this is absolutely not a label. This is a snapshot of where I'm perceiving that they are right then from the information that they're giving me. Can they remember everything that they've done? Are they defensive? Are they not sharing? It depends on the safe environment that I create as the counselor. I provide this. I have to let them know that this is therapeutic. And the idea of this is that we're going to progress and we're going to move forward. So I need to get good, solid information. That's the idea with somebody on your team. You have to make sure that you all have the same philosophy, and you have to know where this other person's coming from, their knowledge level and their skill level in getting the correct information from that person and being part of their team where they are held accountable with you to move forward through the stages of change. So the stages of change are pretty easy. The first one is pre-contemplative. That means I don't have a problem at all. Or, yeah, I do have a problem, and it's you. Get off my butt. Leave me alone. Then there's contemplative. Every single time that I get into trouble, this substance is available, or I'm using it. There's a correlation. I'm contemplating change. Then there's preparation. Okay, I know I have a problem. Everybody's telling me I have a problem. I know where to go. I know what to do, and I'm going to do it for sure tomorrow. Always tomorrow. Then there's action. That's the person's actually doing the deal. They're going through the ups and downs of life. They're getting appropriate care. They're having medical, psychological, substance use, all of the treatment, and they're moving forward. And then we work on their lifestyle, and then there's, maintenance. Maintenance is after a few years where they wouldn't use if you gave it to them for free. And then, relapse is a stage of change. We treat relapse like it's a bad thing. We treat relapse like, oh no, they relapse, so now they have to go back to pre-contemplative and they have to start the game of life again, spin the wheel. No, they can go right back into action. Actually, that relapse can be one of the most powerful messages that they get, especially if they have a bad experience or they get into a fight with their person, whoever's important in their life. Relapse can be really a powerful tool to use to keep them on the road. Then lifestyle changes. This isn't going to help if we work with this person and then just let them go after a couple of sessions back into the environment that hasn't changed one bit, and we're expecting them to change everything in their life. So we have different levels of care, and they don't necessarily have to jump into all of these, but there's residential, that's 24-hour monitoring and structure. It's usually 28 to 30 days, and the person goes in and they're taken care of, everybody's watching them, they're real resistant in the beginning, and then as the time goes on, they get more and more accepted to where they don't want to leave at the end because they're eating healthy, they're meeting other people, they're exercising, they're doing things that are completely different than they're used to doing, beating up their body. Then we have intensive outpatient. Intensive outpatient is 3 hours a session, 3 sessions a week with a support person and a individual counseling. Then outpatient. During this time, they're going back into their environment, they're working, but then they're also getting all of that care that they need. So it goes down titrates down, as the monitoring and structure goes down, their accountability and their responsibilities go up. So we're preparing them to launch into their life with an end result and a timeline. Remaining in treatment for the adequate amount of time is critical. That's pretty obvious. Medications. So methadone, Schedule 2, controlled substance. It has street value. It's used in the oral form as an evidence-based maintenance treatment for documented opioid addiction. Full agonist of the mu-opioid receptor, possible overdose, continuous doses, and successful outcome studies. So the studies are there to show that it is effective. Buprenorphine, Schedule 3 controlled substance, partial agonist, partial antagonist at the mu-opioid receptor. What's important about this is you can titrate up or titrate down on this. If the person is in treatment and they're opioid dependent, you can use buprenorphine to titrate down and ease those withdrawal symptoms. Now, if somebody's in prison and they let you know, or the decision's made that they're going to use as soon as they get out, you can titrate up and get that person to the morphine milligram equivalent that is going to be able to be maintained than on methadone. So it depends on your philosophy if you're going to go up or go down. Then naltrexone, that's the injectable. We talked about that. Full agonist, 28-day mu receptor coverage. Works for alcohol as well as opioids. And Echo has a wonderful MAC clinic. So visit them. When is that, Troy?
Every second and fourth Wednesday at 8 a.m.
Okay, so this is a big deal. Visit our friends for Echo MAC every second and fourth Thursday? Wednesday. See Troy. AB 474, Governor's Bill. Let's do this. Any questions about medication-assisted treatment? Nope. AB 474, the Governor's Bill. Crafted in part by former Chief Medical Officer Nevada, Dr. John Murrow. White paper on the governor's website that explains just about everything. Has anybody visited that? Keep the slides and take a look. There's prescribing changes. They're looking at things before you prescribe an opioid, 30 days into prescribing an opioid, and 90 days into prescribing an opioid. You have to obtain a patient risk assessment. There's another thing. You're going to have to get the ICD-10 diagnosis for the disease being treated, and then create a treatment plan. And a treatment plan is, in my world, that's pretty much what we live by. It's working with the client to make sure that we're both on the same page, and there's a strategy for getting to that patient's goals. And so there's a timeline, and then there's methods, and there's evidence-based treatment, theoretical as well as practical applications that will make this treatment plan a living document that can keep the puzzle moving. So I don't know if you have someone in your office that can do that, but these are going to be new changes. Any feedback with AB 474?
The only thing I've seen is there's been some pharmacies that will call our office and deny fill in a script because we didn't have the ICD-10. And then we've even had some pharmacies call and say they want our office note so they can look at our plan. I thought that was pretty interesting that the pharmacy now wants to see a copy of our note to see what our treatment plan is.
Is that because they feel like they're under the gun too, or that they have?
I believe so.
Maybe,
yeah. I think the other thing I was reading last night is CDS, I think, is having changing laws, and I think in the beginning of the year, they're only going to fill 7 days worth of meds at a time. So I think that's even if you're being compliant and abiding by the law, they won't fill 30 days worth of opiates, CVS pharmacies. So I don't know if that means that these types of patients now are going to have to seek out, other pharmacies or change pharmacies if they previously were CVS customers, go somewhere else to get a 30-day supply of meds.
Whoa. How about the hospital level? Mount Grant, have you, General Hospital, have you had any changes that have come down yet at the hospital level?
On pain management?
On pain management, on AB 474, on MAT?
And it's all still not so clear to all of us, but what we're trying to use is our new EMR, and we're trying to incorporate all of this changes and instructions to our EMR so that it can be a real thing that can work. Because I think all of this notifications, this paperwork that they're asking from us is they don't know how we deal with patients every day. And here comes a bundle of paperwork again that lessens our interaction with the actual patients. I mean, I don't think this will really help the patient in terms of their chronic pain and in terms of their prognosis. And I just look at this as a burden in terms of work for the medical providers. And probably the only thing that I can see positive about it is that epidemiology-wise, it's good tracking system. But on a practical sense, it's an extra burden on all medical providers, especially in the rural setting. So.
You're exactly right. To me, this bill puts the onus on the physicians, right? And it just makes, kind of holds us accountable. But at the same time, if you really want to change the opioid problem, it's got to be a multifactorial changes. There's, you got to have policy changes that probably, at a governmental level, like look at maybe getting rid of pain as the fifth vital sign, or including, pain scores and J-code evaluations. Two, there's no patient accountability with this. Patients can, come in and still get angry and say, I know you can prescribe this to me, even with the new state laws. There's no patient accountability to this. So you're exactly right. This first step here is more putting the onus on us as physicians. And maybe that's their plan, is that if they make it more onerous or more difficult to jump through these hoops, it will be less likely to prescribe, and they'll see the opioid prescriptions, from what we're seeing earlier, 140 million prescriptions between hydrocodone and oxycodone in the state of Nevada. I'm sure they're going to be tracking to see how far that number drops. I'm sure in January, it's gonna drop significantly. We're probably even going to see some issues with maybe even patient abandonment. The primary cares and other people are going to just drop these patients cold turkey, and they won't be able to get into other resources like pain management fast enough. So it's going to be fascinating to see, how much of a change this occurs in January. Yeah.
Dr. Baker, did you have a comment?
Okay, and then prescription monitoring program. My understanding is that it's something that the program can look at every time that you access the program and every click that you hit. So if you're just accessing the program to do some coverage, but then not getting into the patient information, they can see that. And the idea is also they want to see if the patient is using the prescriptions as prescribed or diverting, and misusing or dependent on any drug.
That's tough. I mean, without a drug screen, need more evidence than just the PMP to kind of put the whole picture together, which is interesting. AB 474 initially, it was requiring mandatory drug screens to be done on all patients on these controlled substances at least once a year. But there was a lot of pushback from primary care physicians, and so they dropped it from the bill.
Really? For PDMP, mandatory registration with the state, and I put up a couple of links to get you some resources there, including one for the changes with AB 474. Do we have any questions or comments?
Yes, Dr. Baker, please.
Dr. Baker.
Thank you. From what I understand, that beginning January 1st, that every prescription, and I'm not sure if it's all controlled or if it's narcotics only, on our prescription, we need to have the ICD-10 code on and make sure the date of birth is on every prescription.
And have a relationship with the patient.
Those are those three requirements, yes. Go ahead.
So my question is, does that mean all controlled substances like benzos and soma, or is it just narcotics? That's my question.
That's a good question. I don't know the answer to that. Do you guys?
I don't, right now I know that it's opioids. However, if it's not benzos now, I'll bet you a nickel it'll be benzos in the future.
I will not be betting on that nickel.
Yeah.
You know, the truth is, if you just make the change for all controlled substances, then you don't have to worry about it in the future. It seems pretty, in our practice, we'll e-prescribe anything that's not controlled, but we won't e-prescribe controlled substances. I think at one point they changed the law so you could, but we do a hard script for all controlled substances to make sure we have control over that prescription.
Thank you.
So I'll look into that, Dr. Baker, and I'll follow up with you and then share it at the next clinic with everyone as well.
Thank you.
You're welcome.
Well, thank you all for being here. Have a wonderful week, and we look forward to seeing you next time with Dr. Lewandowski.
What's our topic, Troy?
Ooh, just a second here. I think, Dr. Koss, do you have a comment as well?
Oh, I just had one question. I have a DEA number, and I'm wondering if that's all just a facade. Does the DEA actually engage in drug intervention in the state of Nevada that you're aware of?
So the question is the DEA involved in investigating physicians or?
Not physicians so much, but stopping the sale and procurement of narcotics. Have you ever heard of the DEA actually engaging in the prevention of sale and distribution of narcotics? Has that ever come up in your practice? Have you gotten a phone call from the DEA or patients did? Are they? I mean, is it a completely sham organization in the state of Nevada?
Interesting.
Yeah, I don't know. That's a good question. I know.
Let's look into that.
Yeah.
Thank you.
Okay, so the next clinic will be on December 20th, and it is sleep and chronic pain.
Sleep and chronic pain. Thank you all again. Have a wonderful week.
Nicola, yes?
Oh.
I just want to comment. I have been in a physician's office when the DEA has walked in and three little, suited up and ready to go. They pulled the physician out of the office, now, even though she was with a patient. And then they gave her the option of either turning in her DEA or being arrested.
Yeah, I know they've done a lot of sweeps up in Northern California and Susanville. I know there's 2 or 3 physicians that got paid a visit from the DEA, and I've heard even up in Plumas or Quincy area as well. I don't know if we have somebody on from Plumas, so they can comment on that. But I know that Northern California had several physicians paid a visit by the DEA.
Fortunately, they never went after the drug dealers there.
That's exactly right, unfortunately.
Okay, thank you. Thank you very much.
Thank you, everyone.
Thanks.